So we are going to begin our Zoom conference this morning. We're grateful to those of you who are here with us. I'm Susan Lurch. I'm HFM's Executive Director and also the Great Lakes 5 East Federal Regional Director for the HTCs, the Hemophilia Treatment Centers in Michigan, Indiana, and Ohio. And we're grateful to have you all here with us today. I'd like to thank our technical team, Sarah Precario, who is our Communications and Advocacy Director, and Tim Wicks, who's our Camp Director and Youth Services Manager. So we all have an abundance of different activities that we're responsible for now in this new work at home environment that we're in. I'd also like to thank Sue Adkins, who is retired from Michigan State University, HTC, and also is our regional core center specialist, we call her, and she works with all the HTCs across Michigan, Indiana, Ohio. And our special guests this morning are Jim Munn, who is the University of Michigan HTC nurse coordinator and has a whole bunch of other accolades. And if you ever want to see them all, it's kind of amazing. You can look him up online, and he is one smart guy. And we're grateful that he's here with us. And then Dr. Steve Pipe, who is also has like a billion accolades and has been doing so much for our community. He's just an amazing guy, and he is the medical director for the University of Michigan HTC, as well as being the chair of the Medical and Scientific Advisory Council with the National Hemophilia Foundation. So thank you both for being here. HFM, in our role as the Regional Core Center, has been offering twice weekly gatherings of the HTC team members, physicians, nurses, social workers, physical therapists, data managers, so getting together for the last several weeks to share what's going on in their particular HTC and how they're being impacted by the coronavirus, COVID-19. And so we're going to ask Jim to begin the presentation today with an overview of COVID-19 and his experience in the impact at U of M, as well as listening to his colleagues across our region. So thanks very much, Jim. Thanks very much, Steve. And we'll get to hear from both of you. And Sue, coming up.
Awesome. Thank you so much, Sue, for the nice introduction. And I will say that anyone who's on the call, you should realize how much the Hemophilia Foundation of Michigan has been on top of this situation from the get-go. Sue already mentioned that we meet twice a week, and what that has done is allowed us as a region to talk about this virus and its effect on our patient populations. I will start by saying this. Luckily, in those discussions, we have had very few instances where any patients with hemophilia and bleeding disorders have had much exposure to the virus. Just to start off with, as far as the COVID-19, I wanted to make sure that everyone knew up front that the susceptibility to the virus is the same essentially for everyone. What we get nervous about is whether or not something happens based on underlying conditions that may make the exposure or your reaction to the COVID-19 more difficult for you. And what we realize is that seem to have the most difficulty with COVID when they've contracted it are those who are over the age of 70, people who are immunocompromised, people with other underlying diseases or what we call comorbidities, such as diabetes, heart disease, obesity, just a few of things that they've mentioned out there. And then on the list also were, at one point, women who were either pregnant or breastfeeding. Now there has been some change somewhat to that on whether or not the women who are pregnant might be at greater risk, but I think for us, we still try to keep that as one of the top things in our minds. So from that standpoint, having a bleeding disorder does not mean that you're more susceptible to the virus. I happen to have the opportunity to do a similar call like this where the other attendees or the presenters were from the East Coast. So there was a pediatrician from New York and an adult doctor from Philadelphia and another pediatrician from the Boston area. And even with their high populations of patients, they still were not seeing a lot of patients contracting the virus. So that's a good thing from our standpoint.
Thank you. Sue, do you want to go ahead with the questions?
Yes, Steve was going to, Dr. Pipe was going to do an overview, a little bit about COVID-19, and I'll just turn it over to you, Dr. Pipe.
Sure. So one of the things that comes up with is why is this even an issue on a global scale? So COVID-19 refers to the clinical features of presentation with this infection, but the virus is actually called the SARS coronavirus 2. This is the virus that first originated, we believe, in the Wuhan city in China, but now has spread globally. And the big challenge with this infection, and really to distinguish from things like seasonal flu and other coronavirus, is the fact that this is a brand new virus for the world population. So no one is starting with any prior immunity to even viruses that look similar to this particular coronavirus. So with that, the expectation is that patients with bleeding disorders worldwide will almost certainly be impacted by this illness. But thankfully, what we know so far is that majority of individuals, probably up to 85% of patients worldwide, are going to manifest only mild or moderate symptoms of the COVID disease. So those mild, moderate symptoms, what should we be expecting to see? Could be fever, respiratory symptoms, but their oxygenation level in their blood will be normal. There'll be no chest X-ray findings, and usually this will resolve over several days, maximum of probably up to 2 weeks of illness. In the more moderate spectrum of the disease, patients can show up with low oxygen levels in their blood. They may have chest X-ray findings, and those with severe low blood oxygen are going to be admitted to the hospital. And of those, a subset will continue to have progression of their disease. And we know that many patients have ended up in the ICU level of care, including the need for mechanical ventilation. And it's these severe patients that have contributed to those that have gone on to die from this infection. What's that proportion? We think about 15% of patients who contract the illness are likely to end up requiring hospitalization. And then of those that are admitted to the hospital, maybe about a third of those may end up requiring ICU level care. And certainly those that end up in the ICU, particularly those on a ventilator, do have a significantly high risk of mortality from this condition. Jim mentioned the risk factors. Best we can tell globally, and this is accumulating data, including from hotbeds of activity in some countries, there's no evidence that having an inherited bleeding disorder alone is associated with either an increased risk of acquiring the COVID infection or progressing to more severe disease or an increased risk of mortality. So all of those comorbidities that Jim mentioned, those are the ones that we really should be concerned about. So are you older age? Do you have underlying cardiovascular disease, diabetes, obesity, chronic respiratory disease? high blood pressure, those with cancer, and other conditions where they might be on potent immunosuppressive agents. Even having underlying hepatitis C and HIV does not put you at increased risk of this infection or of a worse course, as long as your disease is well controlled. One of the things that we have been dealing with in the bleeding disorders community, we've been trying to stay on top of challenges to the product supply chains. And what's been great so far is that we really have not seen disruptions. Manufacturing is continuing, distribution and even home shipments have been continuing. We are seeing an impact on reduced blood and plasma donations. And so that is a concern for those that rely on blood products and blood plasma and components that are derived from those. We are dealing with the reduced access to the healthcare facilities and the hemophilia treatment centers. There have been postponement of elective surgeries. There have been really negative impacts on the clinical research programs. Essentially, all of the clinical research programs at almost all hospitals have been completely curtailed down to very minimal activity. And then the other thing that's been a challenge, and one of the reasons we're having an exchange like this, is we've seen cancellation of many of our in-person educational and research exchanges, including our regional meetings, our national meetings. You probably heard that the National Bleeding Disorders Conference is also going to be going to a virtual format. So what this risks is compromising the advance and the dissemination of important knowledge about the care of hemophilia or other bleeding disorders, specifically during COVID. One of the most interesting things, and this is a source of multiple questions that came in before this, is the recognition that part of this infection includes a very interesting, what people would call a coagulopathy. So what do I mean by that? So the patients who've presented with severe COVID infections have all kinds of abnormalities in their blood coagulation system. Our blood coagulation system is a balance between what we would call the procoagulants, those that activate clotting, and then the natural anticoagulants, which keep that clotting in check. And what we're seeing with COVID infection is that a lot of the procoagulants are elevated. These include things like factor VIII, von Willebrand factor, fibrinogen. And then concomitantly, we've seen that some of the natural anticoagulants have actually been decreased. One of the markers that we can measure in the blood of appearance of this coagulopathy and then progression is a biomarker in the blood that we call the D-dimer. The D-dimer is a breakdown product from when clots formed. And if you can measure it and there are very high levels in the blood, that tells you that clots are forming and then your body's breaking those down. And the physiology here that we're seeing is consistent with something that's called thromboinflammation. And what does that mean? Well, there's a lot of interplay between inflammatory processes in dealing with an infection and then the coagulation system. And this particular COVID infection seems to really ramp up the inflammatory signals in our blood, and this is probably contributing to the coagulation abnormalities. Why is it important to recognize this? Well, we now know from lots of good data being published now is that the presence when you're admitted to the hospital of having the coagulation abnormalities, and then if that progresses over the course of the hospitalization, this is definitely associated with more severe disease and even a higher mortality. The clinical experience is that patients are presented with deep vein thrombosis, so think leg clots, pulmonary embolus, but we've also seen what people would call arterial events, and you may have heard some of these in the news. Patients are presented with strokes and even a loss of circulation in certain limbs. Now, when I'm mentioning patients here, I'm just talking about COVID infections in general. So one of the interesting things is, are we seeing this in patients with underlying bleeding disorders? Well, let's go through a little bit more about the pathology that's going on here, because I think there's some encouraging news here for patients who have an underlying bleeding disorder. So the two key pathologies that we're observing here is an exaggerated inflammatory response to the infection. So this is a respiratory illness. It infects the pulmonary system, and then there's a response in your body to the infection that gets exaggerated. And part of that exaggerated inflammatory response activates a number of pathways which can make clotting more likely. The second process is this virus gains access to the cells in the pulmonary system through a receptor that's called the angiotensin converting enzyme 2 receptor, or ACE2. You also have this receptor in your vascular system. So think all the tiny blood vessels, including the tiny blood vessels in your lungs, but also elsewhere in the body. And what happens when the virus gets into the lining of those blood vessels is you get an inflammatory response. Some of the cells can actually die because of the infection. And what it can lead to is what we call microvascular thrombosis. So these are tiny clots in the smallest vessels. This is particularly prominent in the lungs. And we think that this clotting that occurs in the tiny vessels in the lungs contributes to the lung pathology and why patients have these very low oxygen levels in their blood. So we call this microcirculatory dysfunction, and it's really a marker of those who are going to go on to advancing severe disease. So those two things, exaggerated inflammatory response and then this endothelial activation and pathology there are really the two pathologies that are driving this coagulation abnormalities. So what we're advocating for all the clinicians who are managing these patients is they check these biomarkers in the blood, and these biomarkers include the standard clotting tests that we measure. And so what are the specific things that we have to be thinking about with bleeding disorder patients? Well, some of their base clotting tests are already abnormal, and they have to be interpreted in the context of whether you're on prophylaxis, whether you've given any recent treatments. And the one biomarker that is really important I mentioned is the D-dimer. We now know a lot about D-dimers in patients with inherited bleeding disorders, and they're not usually elevated. So, and this includes patients who are on factor replacement, but also patients who are on non-factor replacement like emicizumab. The only time we've seen D-dimer elevations in the context of bleeding disorders, and particularly hemophilia, is inhibitor patients who've been getting intense replacement therapy with bypassing agents. So think FIBA or recombinant factor 7A. So if that was the context, people would have to take that into account. But we're encouraging clinicians to be measuring these clotting assays, interpreting them in the context of their treatments, but then also measuring the D-dimer levels to pick this up.
Jim, you need to unmute.
I thought I did. I pressed it anyway. I just wanted to back up a little bit because I don't believe either I or Dr. Pipe mentioned in our initial presentations, this is the same for whether or not you have an inhibitor or not. So having an inhibitor does not increase your susceptibility as well. I just want to make sure we mentioned that.
Yep.
Thank you. This is really valuable information. I did want to share with all of our Zoom participants that we ask that you put your questions in the Q&A, and we will get to those at the end of this. We're going to go ahead and continue through the submitted questions, and we'll use remaining time to do the Q&A questions. So, and if you have any technical questions about the use of Zoom, feel free to go ahead and put those in the chat box. So there's a Q&A down at the bottom and a chat box. And everybody's on mute, except for those of us who are talking, but the listeners are all on mute. Okay, Sue.
Yes.
You have the next
Another question. Is there agreed upon protocol for treatment of patients with bleeding disorders and COVID? And also along with that, is MASAC working on any particular guidelines in regards to those two issues?
Right, yeah, so this is very important. So first of all, the special considerations for a patient with bleeding disorder is the respiratory aspects are going to be managed just as they are with other patients. However, if ICU level care is needed, you can imagine patients might need, special accesses, so they're getting pokes. They might be needing to go on mechanical ventilation. And the recommendation would be is that their bleeding disorder should be corrected to go through those invasive procedures. So that means is patients are likely going to be given prophylactic replacement therapy, whatever your underlying condition is. So if you have Willebrand disease, if you had hemophilia, you're going to be getting regular replacement therapy while you're in the hospital so that you can get the proper treatment that everyone else would get related to those intensive procedures. Where the other sort of special consideration comes with bleeding disorder is this coagulopathy that we've talked about so far. It looks like an important part of the management for patients in general are blood thinners, anticoagulants. These include things like heparin infusions, low molecular weight heparin, and even some specialty anticoagulants. Most patients in our hospital who are admitted with a severe presentation are going to be first put on a prophylactic anticoagulant. And then if they advance to more severe ICU care, they're probably going to be on an anticoagulant infusion. So how would you manage that with a bleeding disorder patients? Well, we have managed anticoagulation in all kinds of contexts. There's patients who've needed surgery where anticoagulants are required for surgery. And in some cases, patients with bleeding disorders have had blood clots, and we've had to put them on anticoagulants. So we're not starting from a lack of knowledge here in this area. The question is are the specific pathophysiology that I talked about, does it require special consideration related to COVID? And this is where I would say we don't have enough information to say that we have a specific protocol. I do think it's reasonable that we correct patients to a reasonable level so that they won't have any bleeding from their invasive procedures. But we also probably want to be careful that we don't keep people at really high levels unnecessarily because of that balance that's been disrupted that I talked about. So we're looking for sort of bringing people up to sort of a reasonable level of protection with their clotting factor levels, and hopefully that won't exacerbate any of the coagulopathy. The one thing that I think is interesting, and we'll have to see whether the numbers really prove this in studies that will follow, but if the main driver of this pathology is what we call thrombin generation and fibrin formation, patients with many bleeding disorders already have a compromise in thrombin generation and fibrin formation. That's what gives them a bleeding disorder. So it's possible, if this is a key part of the pathology of severe COVID illness, it's entirely rational to think the patients with bleeding disorders actually are somewhat protected because this coagulation response is going to be blunted because they have a bleeding disorder. And even if you're on prophylaxis, you don't spend a lot of time on prophylaxis with really high levels. Most of the time, you're still down in a mild range of bleeding risk. And so I take some comfort from that personally, from what we've seen. I think it's consistent with what Jim was sharing across the region, that bleeding disorders don't appear to be disproportionately infected. And it may be that even the lack of patients presenting with severe disease could in part be related to the fact that the bleeding disorder may be partially protective.
And
go ahead.
I would just like to say that a lot of the information that's coming out of Italy, because they're further advanced in the process, has also been exactly what you're saying. And there is some good information coming, not published yet, but good information anecdotally from Italy in regards to hemophilia and bleeding disorders in the COVID population.
I talked to one of our colleagues from the Mount Sinai system, which, you know, at one time Mount Sinai had 1/4 of all of the infected patients in the country in the hospital. And what they said is that they've had very few patients with bleeding disorders and no evidence that they've had a more severe course than other people.
I wanted to go backwards a little bit. Dr. Pipe had mentioned the use of invasive lines and things like that. One of the things that some of our patients already have existing is a port. And I just wanted to let people know that should that be accessed in the hospital for use as a line, there are institutional protocols on how to make sure that that does not clot off. So there will be attention paid to that. So having a port doesn't mean that going in with COVID will result in the line clotting off, because there will be measures done by each institution to make sure the patency or the ability for that line to be used is up to par and as high as possible.
Thank you, Jim. You just answered a question that I was about to ask.
That's great. Okay, so we've had a question about previously about, is there another way to swab for COVID-19? And I think I've heard on the news that they're handling things a bit differently. But this individual's daughter had a swab and then an immediate nosebleed, and they have VWD.
Yeah, so this is an interesting scenario. So one thing we should maybe talk about briefly is, what are we doing with these COVID tests? What are they actually measuring? So the COVID virus, the coronavirus that caused this disease, it's got a protein coat, and then inside is RNA. And it's the RNA that gets into the cells and drives the propagation of making more virus, and also hijacking all the production machinery of the individual cell. And that's what makes our cells sick. So what they're doing with these COVID tests is they are swabbing the lining of the respiratory system. So they're accessing that through the nasal swab. And then they're hoping to catch enough viral particles. What the test kits do is they bust open the protein coat and they extract the RNA from any particles that are in there. And then at a lab, they amplify the RNA into DNA, and then they amplify it many times over so that it's detectable. That's the principle of the test. So what they're measuring is the RNA inside the virus particles. So none of these tests actually tell you anything about the infectivity of the patient, because they're just measuring RNA remnants from this swab. So that's why you say, well, why isn't it done from a blood test? Well, it's more likely to encounter the viral particles if you actually swab directly on the respiratory epithelium. What I would recommend is, if you had a bleeding disorder and you have a way to treat yourself before going in for a test, I would recommend doing that to all of our patients. So if they had hemophilia, I would just recommend, if I was sending them in for a test, make sure you've done your pro-feed that day before you go in to have your swab. If you had von Willebrand disease or a plague disorder, you might have access to something like Stimate or Amicar. Or even Listetta, the other alternative to Amicar. It would be reasonable to start taking this before you went in for your test, and then maybe continue that for a couple of days afterwards, because there is risk for damaging the lining from doing the swab. So I think that would be a wise thing to approach this.
And the swabbing itself, you really have to go deep to the nasal passage, as Dr. Pipe was mentioning. And what we're doing is we are swabbing enough that we're capturing enough epithelial cells, because we're trying to see if those cells are harboring the virus, like Dr. Pipe was mentioning. So it's a process that looks almost medieval, because we're going way back with the swab to do it. So I agree with Dr. Pipe. If you can at all, pre-treat before you go to get the testing done.
Really smart. That's great. So this one is kind of the same, except they were suggesting in their household they have both von Willebrand's and storage pool deficiency. Would COVID-19 affect them any differently? Is there anything they need to be aware of?
Yeah, no reason to think that they would be disproportionately infected or have a more severe course, etc. And the same principles for managing bleeding if they came into the hospital for a procedure or surgery would be applied. And there is experience even using blood thinners in patients who have von Willebrand disease and platelet disorders. These can be challenging to manage that balance between the correcting them for their bleeding disorder and doing the anticoagulants. But many of your HTCs, if not all of them, have probably had some experience in doing that in the past.
And the same would be said for rare bleeding disorders, people who might have von Willebrand's and, for instance, Ehlers-Danlos, those kinds of things. They're all the same as far as the fact that there's not an increased risk for developing it, but if something happens, we have ways to manage that.
Great, good. There seems to be more susceptibility in the African-American population. Do you have any knowledge or explanation you can share with us?
Yeah, it's certainly not specific to the African-American population. There's also reports showing increased incidence in the Hispanic population as well. Part of that is socioeconomic, but another part are comorbidities. So our familiarity in our region, African-American population, is higher incidence of hypertension, cardiovascular disease, and then perhaps even obesity. And so all of these are known comorbidities that increase both the severity of the disease and the risk of mortality. So yes, they have been disproportionately affected for that reason, in addition to the socioeconomic challenges.
Mm-hmm. How about being on Hemophilia or fitusiran? Does that complicate diagnosis and treatment of COVID?
Yeah.
We have several questions in regards to that.
Yeah. So let's address that. So first of all, no complication with diagnosing the condition or management of the respiratory complications. There are some special considerations, though, understanding what Hemophilia Libre does to provide prophylaxis for patients. So the difference with Hemophilia Libre versus, say, factor VIII replacement, when we do prophylaxis with factor VIII replacement, we're getting a big peak right after you infuse, and then the plasma levels fall gradually over the next, couple of days until you get your next prophy. With Hemophilia Libre, you build up a steady state level, and then your level is roughly the same, whether you're dosing weekly, every 2 weeks, or monthly. Your steady state is about the same. So the question really comes down to how corrected are you with Hemophilia Libre? There isn't a one-to-one comparator. There's no assay you can choose that says your factor VIII level equivalence is this. However, based clinically, what I think almost all clinicians would agree on is that Hemophilia Libre brings you up into a mild hemophilia range. What that level would be is up for question. It's probably somewhere between 10 to 25 or even 30%, but still in the mild hemophilia range. So we don't consider Hemophilia Libre patients to be at increased risk of certainly of the infection, but also of the coagulopathy. And that has also been borne out across the world where patients have access to Hemophilia Libre. Worldwide, it's approaching 7,000 patients who are using Hemophilia Libre at any given time. And there's been no evidence that any of them have been disproportionately affected with either clotting problems, either as an outpatient or in the inpatient experience. So I think that's all been encouraging. Where we do have to pay attention, though, is I mentioned those clot screening tests. So one of the clot screening tests that is used very frequently in patients who are admitted with COVID is the PTT. This is a standard clotting test. And it turns out that the PTT is really uninterpretable in patients who are on Hemophilia Libre. So because of that, clinicians just need to be aware, and the hematologists who are working with the ICU staff need to remind them that they can't take comfort from seeing a normalized PTT in a patient on Hemophilia Libre, because that would be expected. We do know, and we've had some data provided to us to indicate that there's no indication that D-dimer levels are affected by Hemophilia Libre. That was part of the clinical trial programs. There was data collected in that. So D-dimers can still be used in monitoring patients for that coagulation abnormality.
Thank you. There have been a lot of questions about that. Steve, Dr. Pipe, you may have answered this, but are there issues with FIBA and elevated D-dimer?
So the only publications that have supported that D-dimers have been observed in patients with hemophilia are when they are getting intense treatment with multiple repeated doses, usually in the inpatient setting, and also in patients who are getting both FIBA and Novo-7 together. So either alternated or at the same time. There are publications that have shown that when that's continued for multiple days, D-dimers do tend to climb. And so in that context, it probably is a biomarker, again, for an underlying clot risk. So we've seen it in that context, but that doesn't come up very, very frequently. Just regular home use of FIBA or Novo-7 doesn't seem to be associated with significant and sustained elevations of the D-dimers.
Okay. Sue, do you have any other, I guess are there medicines for blood pressure or heart disease that can cause difficulties that you guys are aware of regarding COVID-19?
Well, I mean, certainly uncontrolled hypertension or just having a history of hypertension that's requiring medication is an established comorbidity and does appear to be a concern. Also, patients who've had a history of heart attacks, other cardiovascular complications. So that sort of history is sort of beyond their bleeding disorder as a risk, but well established in the COVID patients who've been in the hospitals.
Great.
Yeah.
Go ahead, Sue.
So if a person that's listening to this is diagnosed with COVID-19, what should they do and who should they notify?
Well, Jim, maybe you want to walk through what we would be expecting from our patients.
Yep, I certainly want a phone call to us, but I want you to contact all of your other care providers, especially if you happen to have other comorbidities, because everyone's going to want to know. If you contact us, then we have to decide where is it that you're going to go, if in fact you even need to go. So we have established a COVID hotline at our institution that we will send patients to get answers to their questions ahead of time. If we need to have you admitted at our institution, we have a process in order to do that. Just know that currently we still have some restrictions on the number of visitors and things like that that will occur. So if you're coming, please remember that you cannot have a car full of people coming with you to get admitted, because we will not allow that, especially if we have the feeling that COVID is in the background or positive for the patient. I would say one thing that I would like people to think about, and this pandemic has done it for me as well, I am not a doomsday kind of person. I don't have, a year's worth of food stocked into a shelter underneath the ground at my house or anything like that. However, I think it's appropriate for everyone to take a look at your medical directives, wills, and things like that. Not because I think anyone is gonna pass away from this, but it's just a smart thing to do. In fact, I'll just share my instance. I went back and I checked my will, and it was done so long ago that my youngest daughter was not on it. So I had the opportunity to make that change. It's just simple things like that. But it might give you some peace of mind just to know that those things are taken care of.
So, Jim, how important do you think it is for people to be wearing masks and things like that?
I'm a big proponent of masks, social distancing, not touching your face, washing your hands frequently, making sure that you, if you cough or sneeze, are using the crook of your arm or Kleenex or something to actually blow into and not your hands directly. So I'm a big proponent of all of those measures that have been identified by the World Health Organization and the Centers for Disease Control as ways to help prevent the spread of this virus.
Mm-hmm.
Sue, I just wanted to go back because I didn't get to address the issue of whether there was going to be hemophilia-specific guidelines presented from anyone.
Oh, okay, thank you.
So we did issue a couple of recommendations, mostly related to supply issues and reassurance for the community. We did also update that related to the state emergency disaster plans and the shelter in place. And so there was a allowance there for earlier refills for patients so that they could ensure that they had at least a 2-week supply, which is consistent with our prior guidance. So we did address that. And then I, as the chair of MASAC, I also sit on the medical advisory board for World Federation of Hemophilia, and we formed a COVID task force. And if you go to the WFH site, you can find all of the task force recommendations that have come from WFH, including special considerations for the hemophilia community. So we have been engaged on this. As far as specific protocols for how you would handle anticoagulation in a hospital for a patient who needed it, who had an underlying bleeding disorder, there have been some consensus guidelines that are being drafted currently, and we're hoping to get those through peer review and then hopefully a publication that will come out quite soon. So I think in the coming weeks, we should be able to see that. And those are not going to be, they're only partially evidence-based because we haven't had a lot of patients to learn from at this point. But we do think we have enough information to at least give clinicians a starting point based on expert consensus. And then as data is collected, we can learn from that and see if we need to make adjustments to those consensus recommendations.
Great. We did have a question that popped up. You had talked earlier about the very small number of patients who've been impacted. Certainly in our region, from anecdotally, it's small. We are asking people to keep track of that. But do you have any idea worldwide or?
No, we don't. Although the network in the U.S., AFN, American Thrombosis and Hemostasis Network, they do now have a mechanism for tracking affected patients who are seen at the HTCs. So I hope that in the latter months here, we'll be able to have a look back and see what proportion of our patient population has actually been affected and what their outcomes are. I think that'll be really valuable information.
And I think with our HTC regional meetings, we've been having conversations about this, and it's probably only, Jim and Sue, do you recall, it seems like maybe 3 patients or something like that. Yeah. It's been a very small number.
Very few.
Right.
So.
So I see that someone had asked here about the impact of halting research and advances on new hemophilia treatments, including gene therapy. I think this is an important concept. Yes, our clinical research activity has been dramatically curtailed. The good thing is that from the gene therapy front, most of the phase 3 trials had already fully enrolled and dosed patients. And so I believe all of those trials are going to continue to their endpoints. We have heard of some of the phase 3 trials and phase 1 and 2 trials, the earlier phase trials, that hadn't dosed all of their patients. And there have been press releases indicating that those programs have been suspended until there's a ramp back up on clinical research activity. I think that just makes sense. And really, they have to adapt to the restrictions at the individual centers who are doing the clinical research. So I hope it really doesn't set us back terribly. But this is an ongoing concern for a host of other new therapies that are in development. So we really hope that we can get through this and then start to ramp up that activity again.
Other questions that have popped up, let's take a look. A lot of it was you've talked about in relation to emicizumab. Let's see.
Well, people have asked again whether there's any special concerns for the Hemophilia Libre patients. Yes, we have seen thrombotic events in patients with Hemophilia Libre. Those again were associated with concomitant use of FIBA in the clinical trial program, and those warnings and the proper management of bypassing agents is well disseminated to the community. I think all of our HTCs have done a very strong job of educating patients about that risk. So that's completely independent of the COVID issue. I think even more so, a patient with hemophilia who's on Hemophilia Libre, and then if they did have an active infection, and particularly if they had to be hospitalized, we would certainly want to strive to avoid use of FIBA and rely on Nova 7 for any bleed management control in those patients.
Okay. Someone asked about COPD, asthma.
Yeah, I mean, I'm definitely not a pulmonologist. I think these are important comorbidities that would be taken into account by the ICU doctors and the pulmonologists who are caring for patients. I think one of the interesting things about this particular presentation is the very low oxygen levels that patients present with. Maybe that's being driven by the microvascular circulation issues that I mentioned at the beginning. But as far as whether, you know, what the implications would be on top of that if you had a bleeding disorder, I don't believe there would be any. I think they would manage them as they would other patients who have that comorbidity.
I think probably the gist of the discussion from Dr. Pipe was this, that comorbidities have to be taken into consideration. And if you happen to have any of them, so if you have the COPD, the asthma, the pulmonary disease, you are the person that really needs to be the stay at home, isolate yourself.
What I was going to say.
Higher risk for getting it, but if you get it, your complications could potentially be worse. So I want to make sure that you're not the person out in the store without a mask, you know, reaching over people to get canned goods, things like that, because I don't want you to put yourself at increased risk for getting the virus.
Right.
Thank you, because that was exactly what I was going to say. The nurses always think about the same way.
And the need for both parties to be wearing a mask. So you're protecting yourself, but you're protecting others. And in our community, we care a lot about each other. I've often said, even if people don't like each other, they still care about each other in the bleeding disorders world. And so I think that's really important to recall. So do we have any, I think that we're in pretty good shape.
There was one question.
Oh, go ahead.
I'm sorry. There was one question in the Q&A section talking about, would things be worse because the extrinsic pathway is also being utilized, or
Yeah, so again, maybe a specific question about our Heme Libre patients,
Mhm.
any worse off. There's no evidence that they are. Now keep in mind that Heme Libre is accomplishing similarly to factor replacement to make a more mild expression of the bleeding disorder of hemophilia A. And Heme Libre only takes patients up to a mild hemophilia range. There's nothing that we've learned from either patients who've been admitted to the hospital or who are in the community who are on Heme Libre. It doesn't appear that they're showing up in disproportionate numbers with any new clot events. Remember that because we have brought this new treatment to the community, we had set up multiple mechanisms for tracking adverse events. And so there's nothing accumulating in those adverse event reporting mechanisms to suggest that COVID is triggering any unique pathologies. But one thing I would say, though, is because this is a dysregulation of the balance of proclotting and natural anticoagulants in the blood, I'm talking about COVID here, whenever you are closer to the normalized range, then your risk is going to be the same as people who do not have bleeding disorders. That's how I would think about it. So if you are fully corrected through your prophylactic replacement, then I think your risk should be viewed in the same way as a person who doesn't have bleeding disorder. And Heme Libre is taking you a partial step in the way to normalization of the blood clotting system. So I think that just needs to be kept into account. So for instance, if a protocol in a hospital would be that you get admitted to the hospital with COVID, that you get put on a blood thinner, then I would advocate that the patients on Heme Libre should also be on a blood thinner. We've published, including from our experience at Michigan, you can administer blood thinners to patients on Heme Libre, and they tolerate that well without any excessive bleeding. So we want to make sure that if any of our bleeding disorder patients, regardless of the treatment they're on, get admitted to the hospital, that they are offered a standard of care that would help them have and achieve a good outcome.
And Steve, there was one more question about patients who have a baseline thrombocytopenic picture, platelet counts. They're not at any higher risk for developing it, but again, because there has been episodes of things that look very similar to DIC and things like that, what does that mean for those patients?
Yeah, so we just want to make sure we're helping our ICU colleagues to understand the context for their low platelet count or the platelet dysfunction. Some patients have both. And that could challenge how they manage those patients. I can tell you my own experience having to do blood thinners management in patients who have very low platelets. This is challenging. And so I think that's something that HTCs already have experience with managing in various scenarios, and close communication between the HTC staff and the ICU care team is going to be helping patients have a good outcome.
Well, thank you. Thank you all very much. Thank you to our participants and to our HFM colleagues and team, and especially to Jim Munn and Dr. Steve Pipe. Is there anything that you two would like to add here at the as we wrap this up today?
Well, I would just like to say how impressed I am how the HTCs have come together and rallied around this regionally, on a global scale. The advocacy groups, I hope you've all been taking advantage of Dr. Valentino's health and wellness seminars. I think that's just great. WFH has been doing webinars as well. The community is really banding together, and they're making sure that even though we're challenged in our communication venues right now, we're taking advantage of these technologies, and people are really getting the news out, and I think it's helping our treatments at our centers, and it's also helping our patients to know that the wisest minds have been thinking about this and trying to communicate this to the community.
Yeah.
I echo those sentiments. And again, I really want to say thanks to HFM for taking the lead on making sure that we touched base as a regional community and made sure we had good contact with each other. The other thing that I want to say out there is there's probably going to be a lot of disappointed youngsters that camp is not going to be held in person, but it is going to be virtual. So watch for information. It's going to be coming soon about how to register for camp and how we're going to address that this year. I'm really excited about that component.
And we are too. Thank you for sharing that. And we encourage people to take a look at HFM's Facebook page regularly. We are doing all kinds of programming and other chapters and organizations, clearly NHF, World Federation, and the Hemophilia Federation of Alliance. And we're all coming together and providing as much information as I think we can. And we're anxious to be here for our community. So special thanks to our U of M HTC leads and to my colleague, Sue Adkins, for coordinating all of the questions and getting this together along with our HFM team. So we hope everybody has a great day. If you go outside, please wear a mask. Not outside, but you know what I mean. If you're going anywhere, I'm not. I have been in my house for weeks and weeks and weeks. I have one of those comorbidities. And we're going to continue to be working from home for a while yet. So take good care, everybody. We're grateful that we have all of you together. Thanks.
Yeah, the usual tagline, stay safe and healthy, applies always.
Yeah.
Always. Thank you, guys. Thanks, everybody.
Thanks.
All right. Bye-bye.
Appreciate it. We'll be doing more of
Take it
these.
easy.
Thank you.
All right. Bye.